Good afternoon. I'm Bob Blum, and I'm the head of the Johns Hopkins University Urban Health Institute. And it is a tremendous pleasure for me to... Is everyone going to sleep? It just seemed to get dark all of a sudden. I'm not sure that we need the lights quite so low. I mean, it's very romantic, but it probably could be up a bit. That's great. Thanks. Because otherwise Dr. Wyatt would not be able to see anyone except the monitor. This is the second of a series on race and research and medicine and public health that the Urban Health Institute initiated in February when Harriet Washington came, and it is a series that we will continue next year. Dr. Gail Wyatt is something else, and I would say that you are in for an extraordinary experience for those who have not heard her speak, and for those who have, I think, equally so. Dr. Wyatt is a psychologist who currently is at UCLA. She is a professor in the Department of Psychiatry and Biobehavioral Sciences. She is the director of the UCLA Sexual Health Program. She is the associate director of the UCLA HIV program. She is the director of the Center on Culture, Trauma, and Mental Health Disparities at UCLA. She is nationally and internationally known for both her writings and for her speaking. She has a career scientist award from NIMH, an award that she has had for at least the last 17 years, and she has written 5 books. Some of her books include Stolen Women, Reclaiming Our Sexuality, Taking Back Our Lives, and No More Clueless Sex. Dr. Wyatt has a very diverse set of experiences, from her current position to her first position here in Baltimore, working as a school psychologist in the Baltimore City Public Schools. She brings a lifetime of research and a lifetime of living to the work that she does. And so thank you very much for being part of this series and helping us to foster a conversation. The purpose of this session is not to have one more good lecture. We will have, in this session, one more good lecture. The purpose of it is to ignite conversations within the School of Public Health, within the schools of medicine and nursing, and between this institution and the community in which we are embedded. Our goal and our intent is to do our work, our research, our teaching, and our community engagement in a different way and in a better way. And as the title of her presentation goes, I think so it is for this entire series, that you don't know where you're going unless you know where you have been. And part of this is to explore where our neighbors have been, where those who live in East Baltimore have been, to understand why there is so much mistrust and distrust, where it came from, not to relive that history, but to get beyond it, to do our work together with our neighbors better and differently than we have in the past. So thank you very much, Gail, for fostering this conversation. Let me just mention the way that we will work is that after Dr. Wyatt's presentation, I'm going to ask the panel to join us. And you each have or can have cards. On these cards, please write questions or anything else you want to write. Raise your hand. Someone will pick it up magically from the air. We'll swoop it away, and we'll incorporate it into the conversation.
That sounds great. Thank you so much, Dr. Blum, not only for such a warm and memorized introduction, but also for inviting me. And I feel so welcome. I spent the day here talking to friends and hopefully new friends, and I want to thank each and every one of you for taking the time to end the day here with me and with our panel. I hope that we'll have a very stimulating discussion. Okay, I don't know what I'm doing. Okay, it keeps going around and around. Okay, that's it. Okay. I want to thank David Holgrave for emailing me first and making me feel welcome, and then it sort of went down the row of Dr. Blum and then Amy and my team, Sean and Brenda, who helped me to put this presentation together. So the whole experience has been an interesting one. I've been dealing with a lot of different challenges at home. Some of the stimulus opportunities have been presented to us, and so this is a rare moment when I can sort of step away from what I'm doing and take some time to reflect in a city that I've lived in and had some interesting experiences in, but also come away refreshed and ready to go back into my life, more committed than perhaps I was in the past. Martin Luther King was a very special person to me. I met him personally, and I spoke at noon about how I first met him and how I felt he was speaking to me. And I think he's speaking to all of us when we talk about health and the injustices in health care being one of the forms of inequality. And I think that I've used him as a real mentor in my life because when I first heard him speak and when he spoke to me personally about some of the things that I wanted to do, I really felt that I was on the right track because he endorsed my career doing something out of the box. And I always seek people who are doing things out of the box because I know it's not easy to do things that are innovative and that you consider that other people will wrestle with. So if you never invite me back, I want to thank you now for having done so, because I want to just tell you from my heart and also from my head what it's been like for me to know where I'm going and where I was from, to be able to come up with another direction. There's some things that have happened to my life that have been very positive, and so you get to see history. You get to see a dinosaur who's still breathing fire too. In that, I was the first African American woman to be licensed in the state of California, which was the whole story within itself. The first minority to receive a K award from the National Institutes of Health. That within itself was a whole story, because I had to get an R01. Those of you who don't know what the gold standard is, an R01 is the gold standard. So I had to get two very coveted awards at the same time from NIH, and I didn't even know how to write a grant. So it was quite an experience, and my ability to find the mentors who would help me to write the grant that I wanted to write on the sexual experience of Afro-American women, which was funded in 1980, is a whole story. But perhaps at another time I can tell you all about all of those things. So I really wanted to start off with the competence that I think we as health professionals really need. Because it is absolutely critical today that in this diverse society and with all the opportunities we have, that you are left with the need to know a lot more than you do today. I certainly feel I'm continuing to learn about different groups and their experiences, their cultural background and their histories, which helps to inform me in the ways in which I need to approach not only my small clinical practice, I still have a private practice, but also my research and mentoring, advocacy, all of these things that I think are extremely important as a health professional. I've testified before Congress 8 times, and before Senator Vice President Biden now, many of those times. So I've had the experience of taking my research from my experiences in the community into Congress, and I've also had the experience of writing up some of those findings, which I'll tell you a bit about, for the lay community, which has probably been the most rewarding thing that I've ever done. So competence involves the knowledge and skills in understanding the value of culture and the impact of disparities. If we are cameras, culture is the lens through which we see. It's just that central that we understand and appreciate the fact that most of the interventions that we develop have no cultural base at all. And I think it's rather disturbing to me, but ironic, that when we talk about sexuality, we're talking about something that's very culturally based. We need guidelines in order to know what to do. We all know that we're born to be sexual beings, but what we do and how we express our sexuality has everything to do with what we learn and what we're told. So without looking at the cultural context of the experiences we have, it's very difficult to understand how to change people's behavior. I'm always interested and intrigued in how most of the research, almost on any topic, talks about the populations most at risk and then goes on to suggest how we should address those populations. In the area of sexuality or HIV and AIDS, usually African Americans are the group that are most at risk for a variety of reasons. But interestingly, the interventions are almost identical to any other group that's mentioned. So I'm wondering, if we're most at risk, why isn't the intervention more relevant to the issues that the group at risk is experiencing? So that to me creates a bit of a problem. So much of a problem, I finally sat down and began to write out what I have been talking about probably for about 3 decades of my professional life, and that is the sexual health model. It's a model that really comes from the history of African-descended people in the United States and really tries to identify the areas of conflict, the areas that are still today very important, that are now moving through in cultural beliefs and values, some religious and spiritual beliefs as well, but I feel are very central to prevention efforts. The first one has to do with body awareness. This comes from understanding your body, knowing how it functions, knowing how the body of the opposite sex functions as well, knowing the importance of touch and looking at the body. One of the things that I do in interventions with women and men is to give them a little mirror as part of their little intervention package, their goodie package, and giving them an anatomical chart and telling them to go home and look at their genitalia. And I can't tell you how many people have never looked at their bodies. They consider their pubic hair to be the no-fly zone, and that somehow that means you're not supposed to have anything to do with that area. So it's really important that we recognize that everybody does not touch their bodies. They don't know that your body is color-coded. If you are brown-skinned, you're bound to have brown all over you. And if it's not brown, and if it's pink, that may mean something different than someone who has more of a pink tone on their skin. And if that's red, then that may mean something different. So it's just these very basic things that we need to talk about with individuals to help them to be comfortable with themselves and to know when to seek help from someone else. So body awareness, why would you think that would be important today? Well, it's because many people did not know, don't have the religious and cultural beliefs that give them permission to know, and really feel it's inappropriate to touch. I have seen a number of men who we've taught to wash themselves so that they don't have to be circumcised. I'm really appalled at how the United States government has gone immediately to male circumcision rather than teaching men how to wash themselves. I think it's very odd that they would consider male circumcision as an HIV prevention without teaching men how to pull the foreskins of their penises back. That's such a simple procedure to do, and yet we never even went there. The first thing we did was to circumcise men, and I cannot tell you how much of an outrage exists in the community because of the obsession with the African descendant male's penis, the size, the location, and then the intervention being one to cut it, minimize it. And some people, and some of the men are just grimacing. You should see what I'm seeing. Some of the men are just grimacing. But to alter it, when this has been the major source of some of the stereotypes about black male sexuality. Most of the doctors who are implementing these procedures are not African American. They're not African. Usually they may be from some other country. So we have to be extremely careful about what we propose, because some of these issues have long established histories, and what they do is create more of a separation when it comes to HIV prevention and not less. Sexual ownership means taking responsibility and control of your own sexual health. That is knowledge of your body and how it works. And now, regardless of externalized control, abuse history, or relationship status, sexual ownership for the first 400 years of this country was something that some people did not have. It still is around the world. Not everyone can say that they make individual decisions about their own sexuality. Certainly we know that's true during slavery. Certainly we know that's true in different countries like India, some parts of Africa, some parts of Asia. Some religious groups do not condone women taking responsibility for their own sexuality and making their own independent decisions. So when a person owns their own body and they make their own decisions, that's usually something that has to be learned, not something that they would consider to be something they already know how to do. And I say that it has to be regardless of externalized control and abuse history, because many individuals who have histories of abuse and violence do not feel that they have control of their bodies. They're used to somebody else telling them about when and how to have sex, but they don't have the experience of making those decisions on their own. Finally, interconnectedness is one of the most powerful values and customs that exists within the African American community, because it's the main reason that we survived slavery. It has to do with valuing family and identifying with individuals who were nurturing regardless of whether they were biologically affiliated with us or not. And because of the village concept, which Hillary Clinton was not the originator of, we as a people, when brought from Africa, were able to identify kind people who took care of us if we were separated from parents. And so for that reason, interconnectedness is still a very powerful value today. Powerful in the sense that with alone, a person is not perceived as nearly as powerful as they are if they are in a family context and in a relationship. It also means that people outside of your biological family can and should be connected to you as a source of nurturance, as a source of love and support. So interconnectedness is an important value. However, all of these three concepts can work against HIV/AIDS prevention. And I want to be able to show you how they can both help and they can both hurt if not explained adequately in interventions. So these are what we call culturally mediated concepts in culturally mediated interventions. And these issues should be addressed. They usually, however, are not. We have piloted these concepts on African American and Latino women, and I'll talk about that a little bit later as well. So just to give you sort of a conceptual organization of what I'm going to be discussing, I want again to go back to explaining the value of culture, that it provides the context around the individual, helps us to understand the rules that they use in order to make decisions about their lives, their bodies, their relationships. And without an understanding of culture, we're really looking at individuals as if they have no rules, as if they're really making their own decisions, which is usually not the case in probably anyone that we know. But I think from a public health standpoint, this is particularly of concern to me, because I think that everyone has a context. Even when you have sex anonymously, there is a context. And for us not to understand or ask about under which circumstance are you having sex, not just how many partners you have and how many condoms do you use, but when do you use them, we will find that there is great variation in the context in which people engage in self-protective or risk-taking behavior. Let me give you an example. We have asked women and men, when do you use condoms, if you do at all? Many people will say, well, when I'm having sex with someone the very first time, we may use a condom. But the second time, we know each other. Therefore, there's no need to use a condom anymore. And you think, how does that work? Because what do you know differently from the first time to the second time that would indicate to you, you no longer have to be concerned that this is a strange person? What's the fact that they're having sex the second time? But of course, that tells you nothing about their risk status. But you see, we have to really get into how people define knowing their partners. Some people consider that to be a long-established relationship because they're having sex for the second time, which means the rules are very different that time than they might be from the first. So we know that people not only don't use condoms, they don't use condoms consistently, and they have different definitions about sex and self-protection. And if we don't get to all of those, we really can't change behavior. Now, what does cultural congruence mean? This means that you're developing an intervention based on the strengths and the cultural beliefs of a group, not the weaknesses that we find if individuals are at risk for disease transmission. That's what I mean by a weakness. And the congruence requires a proactive approach, finding the strength, finding historical strengths, finding beliefs that would help individuals to want to change their behavior. Okay? And usually that comes not just from focusing on individuals, but focusing on individuals within the context of relationships or families. Because we find that the nationalism, the sort of the altruistic approach of helping individuals understand that they're not just living for themselves, they're living for their legacies. They're living because they will become an ancestor of individuals who will go on living, that sometimes gives them a special importance regarding self-protection. When I first started doing work in HIV and AIDS about 1994, we got our first grant that was AIDS specific. I absolutely could not get funded before 1994 in the United States, but I started doing international work like in Jamaica before that, and I can really tell you the politics in California are really very fierce, because I had to compete with San Francisco, who in the 90s was roaring when it came to getting HIV and AIDS monies. But when we finally got money to study HIV positive women, I was told that it really was not going to be a good use of time, because we really didn't know what would help women to adhere to a intervention, and we were just doing longitudinal studies at that point. So I said, well, I know what will help women to want to change their behavior. And mostly men asked me, and they said, well, what do you think? And I said, it's going to be their children. I don't even have to do that study. If I tell them what will keep you alive, what will make you go to the doctor, what will make you take that medication that was pretty much in the mid-90s based on the bodies of men, you know, the body mass of men, not women, because women weren't involved in the first clinical trials for HIV medications from AZT on. They would say, oh yeah, it's my children. I want to stay alive for my kids. So there are things in people's lives that will help them to change. We simply have to find them. I think the voting of African Americans in this last election said a lot. There was more African Americans voting than any other time. And when you asked people, when there were exit polls, what did they say? It was somebody like me that I could relate to. And so I wanted to vote. For the first time, people voted. It was amazing. And when they had that little voting in Georgia after the major election, African Americans didn't vote. They didn't have an Obama, so they went home. They stayed home. They didn't vote. So we really need to understand that within the context of individuals, we have to look at what's important to them from their eyes, not tell them what we think is important or what may be important to some other group. Now, you absolutely know this slide, don't you? You know that where the people are at risk, and you know that African American men are at most risk, men who have sex with men, the highest risk. So I just put that in there just in case somebody didn't know. But these are some of the things that I want to discuss with you, because this is really where my work, I feel, got really complicated. And it took me a while to figure out. But I want to talk to you about the mimic factor. There's some things that can happen to you in life that end up with the same outcome as other things. But if you just look at the outcome, you won't really know what was the thing that created the outcome. Does that make sense? Now, I could have said that in a more academic way. I could have talked about etiology. But I want to tell you about things, all right? Things that happen to you that look like other things. Now, when we look at high-risk behavior, we're looking probably at people who are not using condoms or not using them consistently. They're having high numbers of partners. High could mean more than 2. Did you know that? If you're a researcher, you can have people from 2 to 10, 15, or 20 partners in the same category when you're analyzing your data. But that's high risk because they didn't have none or one. America still suffers from the myth that not having sex is a good thing. Well, let me tell you something as a sex researcher. Sex is a need. It's not a want. If you don't drink water, that's a need. You'll die. If you don't do something about your sex drive, it will come back to haunt you in some sort of way, shape, or form. So what I do for people is to help them to deal with their sex drive so they don't do things spontaneously and they don't have sex with someone they don't want to have sex with. We see this with the abstinence programs. We know that if you simply train youngsters not to have sex, at some point in time, given that 2/3 of Americans have sex before marriage, they're going to have sex. So what we need to do is train them not only to be abstinent so they can grow up and know who they are, but at the point where they do decide, they'll know what to do. So what I see in my private practice are very affluent families bringing in their pregnant teenage daughters who are 15, who have the abstinence ring still on their little fingers, like the Jonas Brothers. And they all have this little click, you know, and they're pregnant. They're visibly pregnant, and they're trying to figure out, well, what happened? Well, they went to a party, and they had a drink, their first drink of beer, and they just felt really comfortable, and Johnny was looking at them and said, hey, baby, and there we go. And don't know that there were options to have. So when I do double ring ceremonies for the church populations, which I do, I will not do them unless they let me talk about all of the options. And sometimes my daughter, who's a family medicine practitioner, and I do them together, she does the physical part and I do the psychological part. But we end up talking about when you decide who you should talk to, consult with, and sometimes that is a religious person. Sometimes almost we recommend the parents, unless they have abuse histories, where it is not appropriate for you to discuss your sexuality to someone in your family who has raped you. And do we ever discuss that when we talk about some of these experiences in terms of getting parental permission and support? But I won't go there. And then going on to what should you have with you? And so we have these little packets for girls. They not only have sanitary napkins in them, but they have condoms in them. They have all kinds of things in there that they may need depending on if they ever do make that decision. So it is not spontaneous. And do you know I tell the same thing to church ladies who are 50, 60, and 70 years old having sex? They ought to have these little packets in their purses. And some of them have crosses on them and God bless you and all kinds of religious messages. And that's okay with me, as long as they are prepared for what decision they might make. You liked that, didn't you? Okay. God bless you. Okay. These are the things that really get very confusing. First thing is, as a sex researcher, if you don't ask about the sexual experiences that happen because you didn't want them to happen, you're not asking about sex. Because everything that happens that's sexual is not consensual. And this is where HIV prevention falls flat. Because 99% of the studies that we cite and that we take out into the community only look at consensual sex. What did you do? How many partners did you have? They don't ask what happened to you because you did not want it to. If you don't look at both sides, you won't understand the risk-taking behaviors that they report. You won't see if a person doesn't have high self-efficacy, if they don't use condoms consistently, if they don't go to the doctor. Did you know that healthcare is even influenced by histories of abuse and trauma? If you don't understand that abuse and trauma are more likely to occur more than once in a person's life, and that substance abuse should not be an outcome, but it should be a result of abuse and traumatic experiences, meaning that all substance recovering programs, if they don't ask about trauma, are not doing service to the individuals who are supposed to be recovering. How can you recover from drinking when people don't even ask you why you drink? It doesn't taste that good for you to drink that much so that you numb yourself and can't make a decision or even know where you are. You see, we just simply aren't digging deep enough. And we're wondering, why are these rates escalating? It's because we're not doing our jobs, folks. We're not asking the right questions. So you see this little pattern of high-risk behavior, but you can see the same thing in people who have histories of abuse and trauma. So unless you ask, you won't know that these people are not just cavalier and ignoring HIV prevention and are not self-protective, but they also may have other experiences that get in their way. Well, when we started doing these comprehensive sexual histories with the Wyatt Sex History Questionnaire that I talked about at noon, which you can get because it's used all over the world, we found that 1 in 3 HIV negative women have a history of sexual abuse before the age of 18. Now that's more likely than you are to finish college. That's amazing, isn't it, for a woman? And 1 in 4 HIV positive African American and Latino men have a history. Did you ever consider that it wasn't just females during slavery who were raped, that African men were raped too? Does anybody ever talk about it? Does anybody know what that does to a man's sexuality? Do we know? No. It's just like a big elephant, isn't it? So when we looked at HIV positive and negative women, and we controlled demographically for education, income, where the women went to school, where they lived, we found that 1 in 2 HIV positive women had a history of sexual abuse before the age of 18. And people were just blown away by this. Well, what was wrong with these women? It isn't what's wrong with these women, it's what's been done to them wasn't paid attention to. So they grew up with this whole externalized perception of control of their bodies, avoiding health professionals. Because if you talk to people who have histories of trauma, they don't want to go to the doctor. They don't want anyone probing around on their body, making them uncomfortable and triggering memories of someone else having touched them in a very uncomfortable way. So they usually go to emergency rooms, and they don't have charts where you can really look to see what their histories are. They doctor shop. So you really don't have a comprehensive history of them and don't know that they avoid medical care. Okay? If you don't look at some of these things, then you won't understand people's behavior. And we see the same patterns in men. So when we did this 7-year NIMH-funded multi-site study of African American couples, serodiscordant couples, that's where one person's positive and the other person's negative. And we just unblinded that study in November, and the first trial paper's coming out in a couple of months. But if you're interested in how we developed it, because we spent a whole year piloting the curriculum, you can find it in J-AIDS in 2008, and there's a special issue supplement on it. And it's really a work of art. I know I was a part of it, but if it weren't a work of art, I wouldn't say that. Because we worked so hard to make this intervention culturally congruent. That means every single statement that's made to these couples, self-identified heterosexual couples, was made in mind with some of the strengths that we know that individuals have if they are self-identified African American. So we named it the Abond Project, which means fence. It's a symbol of safety, security, and love within one's family. And the study was conducted in New York, in Atlanta, in Philadelphia, and in Los Angeles. And it's a powerful thing. That's all I can say about it because the findings haven't come out. But more importantly than the findings is I wanted to show you how we ask about these questions, because a lot of people are not totally convinced that you just can't ask, have you ever been sexually abused? And you say yes or you say no, and then they've got that history. Oh, no. You've got to behaviorally ask questions, because sexual abuse to some people means fondling, molested, or other people are talking about many, many other experiences I don't need to go into, but you'll see some of them. So we have a whole introduction that says these things happen before the age of 18. We call them child sexual abuse. Since 18, we call them adult. And they could be with a family member, not a family member. They could be pleasant, they could be unpleasant, you could have told or not. So really give people permission to begin to examine their own histories and to tell us if some of these things might have occurred. And the reason we go through multiple questions is so that we can begin to ferret out what happened. It's very important that you know what happened, who did it, how many times did they do it, what was the reaction, did they tell, is not in these questions, but in the larger questionnaire I do ask, did they tell, and why didn't they tell? Disclosure is a huge predictor of psychological distress. So here's the first question amongst these that I'm showing you today. Before you were 18, did anyone force you or put your penis into their vagina or someone else's vagina? This is a male-oriented question. All right. So if they say yes or no, then we begin to ask a number of other questions. Now, while this is on an Acassi, that audio, it's not audio, the interviewer is writing all the answers down, and then we enter it into the Acassi later. This is done face-to-face. And the reason that we do these questions face-to-face is so individuals can ask questions if they're not clear about what they're being asked. We feel that's a very important component to asking the questions. And so we go on to ask, how old were you? How old was the person? Sometimes individuals don't know, so we might ask them anchoring questions or bounding questions like, did you feel a beard? Did you see a mustache? Did you smell cologne? What kinds of scents did you have? And of course, we're looking for cologne or perfume or things like that that might give you a sense this person was a little older, they weren't a kid, okay? And the reason that we don't select out, some people only look at incidents that happen from 14 or younger, and then they look at age 18 or older. Adolescents can be raped, and we don't just require a 5-year age limit between the perpetrator and the alleged victim, because someone your age can also rape you. So some of the criteria that we've seen in other studies, we don't use because they don't really make any conceptual sense. These experiences have been done by children. I've been into juvenile court with people 7- and 8-year-old who are serial rapists today. We have a serious problem in this country because we're so phobic about these issues and really don't want to ask kids or protect them when it happens to them. So we see serial rapists who, of course, at some point in their lives have been abused themselves. That's how they learn to do it. Okay? So we go on to ask them how long did it go on and how do they feel about it? These are some of the other questions, all of which we ask the same series of questions to get a very comprehensive history of their sexual abuse histories. And then we ask the questions of females. All right? And these are individuals who are born female or born male. If we're working with a transgender population, we still want to ask them about the experiences they had when they identified or lived as a male, and then when they identified or lived as a female, because they will differ. And we do not put transgenders in with women who are born female, even though they feel that their experiences are many times the same. There are some questions that the transgenders will answer, but we don't want the other women who are born female to attack them, to criticize them, and berate them if they talk about their menstrual periods, for instance. And so in order to not have any kind of assaultive experiences, we do separate the transgender from the born female women. Okay, so we go through the same process that I just showed you with men, except we ask more female-oriented questions. And they're very, very explicit, and we train the interviewers to look in the eye of the person they're speaking to with body language that's totally neutral, as if you were saying, have you ever changed your tire? Because it's really important. The body language, the eye contact of the interviewer can shape the response that the person being interviewed will give. We've done a dissemination study, a couple of dissemination studies, but one in particular in Los Angeles with 10 community-based organizations. And when we started talking about sexual abuse, we found there was a lot of agitation and argument going on between the facilitators that were being trained and the trainer from my team. And when she came back and reported to me that the facilitators were kind of arguing whether this was really a relevant topic, I said, you know, it sounds to me like something needs to be discussed with them and their histories. So she went back the next week and said, some of you are really uncomfortable with these definitions, and I wonder what your experience has been. Every single woman in that room had a history of sexual abuse. We were asking them to do this intervention that focuses on women's abuse sexual histories But we didn't ask them about themselves. So we had to back up and train the facilitators who were going. We were training the trainers, but the trainers had the histories themselves. So we learned a big lesson, and that is, don't assume that the professionals that you work with don't have these histories themselves. Not everybody can do this. And of course, we were able to weed out individuals who were so traumatized in discussing their own histories, they wouldn't be eligible to run groups where women are going to be talking about this each week. That would be re-traumatizing them. So I'm saying this to you because if you are in a position of hiring or giving these kinds of interviews, you need to look at your own history. You need to understand some of the people who will come to try to volunteer for my research teams are people who have extensive histories, and they want to help other people. But in going through our questioning, I will ask them about their history. And if they haven't received help, then they can't do these histories, because I don't want to re-traumatize them. They've got to get help and go and talk to someone professionally. They can't just jump over that whole experience of looking at themselves and how they cope and then help other people. So when we developed the training and when we developed the curriculum, it's an 11-week curriculum for HIV-positive women, we found that they were more likely to reduce their sexual risk-taking behavior. And if they attended 8 sessions, 8 of the 11 sessions of the intervention, they were also more likely to adhere to taking their HIV medications on a regular basis. And that was published in 2004 in AIDS and Behavior. Now, there was some interest in other professionals in my team to take our intervention and to start again and develop an intervention with HIV-positive African-American men and Latino men. And so they did so. It's called the Enhanced Sexual Health Intervention for Men. And they found similar findings, but much more modest findings. And I want to get back to what I talked about at the noon hour, and that's the whole issue of economics. When we recruited the sample of HIV-positive African-American and Latino men, they were more likely to be unemployed and extremely poor. Many were homeless, living in transitional housing, but homeless all the same. And the men in the health promotion control group also became less depressed as compared to the men in the intervention group. Why? Because coming to a group every week and being fed and being able to talk about their experiences, even though they weren't talking about their abuse, helped them to have fewer depressive symptoms. So sometimes you don't find differences between control groups and your intervention groups, but you have to understand the samples and what you've done and who you have included. So our control group did just as well in terms of reducing their depressive symptoms. There were some modest findings on sexual risk-taking reduction in our intervention, the guys who were in the intervention. But again, it was amazing when you talk about health promotion and going to the doctor to take care of high blood pressure and obesity and all the health problems that are very, very common in the African American community. Many of the men said, well, you know, I'm going to the doctor on a regular basis for all these other things. I think I'm going to go in there and ask the doctor about HIV as well. We didn't even mention HIV. They simply generalized and decided they were going to be that rigorous about their health, they were going to include their HIV as well. So they actually did better. They didn't even get the intervention. And I don't like to make a big point of that. But the fact is they did. They did better. So that was released in 2006 in Archives of Sexual Behavior. So I wanted to tell you a little bit about dissemination, because I think that, you know, as an academician, I can spend my whole life in the university being critiqued every day by somebody and feel very, very powerless to be able to make a difference in the community. I also had the good sense to stop listening to all my academician friends who said you shouldn't write popular books because it gives you less credibility. And I said, less credibility to who? I mean, who cares? I wanted to talk to people. And so I wrote a popular book. Stolen Women is the name of it. And it's a bestseller, doggone it. Has anything that I've written for the academic world been a bestseller? No. So I figured, hey, you know, I've learned something here. And this introduced me to a whole different population of people. People who would never come to a conference like this, but who would come to a bookstore. And were they engaging in high-risk sexual behavior? You betcha. for the same reasons as people in my research. The difference is I was coming across to them in a very different way. I was an author, right? And so they could ask different questions. And while they bought a book and I'd be signing it, they'd be telling me about what they were doing. And I'd say, oh, page 11, check that out. Page 14, girl, look at that. And then essentially, I was doing the same thing that I would do in a more formal intervention, except that you have to look at the message and the messenger. Okay, in that format, people could hear the message through buying books and getting them signed. Who cares how they get the message as long as they get it? Now, I received quite a bit of criticism from the home front because I had gone off to the world without my husband. This was my home front, my relatives saying, what is a married woman doing out on the road without her husband? So you see, I am not from a progressive family. I'm from a very conservative family. And so I decided to write another book with my husband, who's an obstetrician gynecologist. And in this book, we have 20 years of our clinical practices. And we talk about sex. He sees sexual issues from the standpoint of an obstetrician and then brings in the partners. We've both been trained as sex therapists. And then, of course, you know what I do. So it ended up being a very interesting experience working with someone that you're married to, because I almost kill him. He is an advocate of any sports activity, anything on television. And when it came on, he was done. He would just say, well, I've got to watch this. It didn't matter about deadlines. So we have a completely different way of operating in the world. Bless his heart. I just realized we have to find other things to do, but it won't be writing a book together. So, having this template, I decided that I really wanted to get involved in South Africa, which to me is the closest experience to understanding what it's like to deal with a recently oppressed group of people. So I went to South Africa in 1996 with the National Institute of Mental Health. I was one of the delegates that was first there to talk with the Medical Research Council of South Africa. It's one of their privately funded research groups. And I started a little controversy because I wanted to work with all black South Africans. And they looked at me like I was crazy because there weren't any people in the room who were black South Africans speaking about the risks of black South Africans. And I said, well, how can you speak about people that you don't identify with? That made a bit of a problem for NIMH. So it took me 4 years to find the team, but this is a fabulous team at a historically black university in Limpopo, South Africa. It's a northern province. Dr. Sylvester Madu will be at UCLA next week speaking about his work with pregnant women and getting tested in South Africa. But we got a Fogarty International grant, and we train black South Africans, colored South Africans, Indian South Africans, people of color in South Africa to do their own research in their own country. I am not in South Africa running from there to Los Angeles trying to do the research on both sides. And I'm proud of that. That means I'm actually stepping back and I am empowering people from their own country to be PIs of their own research. Can you imagine that? Now, it took me a long time to develop this model because people said I was foolish. I could have gotten funded right after I went to South Africa in 1996. I didn't want to do it that way because I think at some point we need to understand that the messenger is just as important as the message. People needed to be in control of their own healing. They needed to tell their own story. So as of June, we will have trained 8 researchers who work in trauma, culture, and mental health. And it is the most gratifying experience, I can tell you. All of the people in our program have gotten promotions at their universities. They're doing some fabulous work. I can't even describe to you because I don't have enough time to describe some of the things they're doing. But I will tell you about one. One guy is looking at Zimbabwean refugees into South Africa. They're escaping the regime in Zimbabwe, and they're coming into South Africa to live and get work. The problem is, nobody wants them. They're educated, they're taking the jobs of the South Africans of color who've been waiting for their chance to work for money. And now here come the Zimbabwean refugees who are better educated than they are. So some horrible things have happened in terms of conflicts between all these people who are vying for the opportunity to get paid for work in that country. So we're documenting the trauma, we're documenting the mental health outcomes, hoping to develop an intervention for these folks who will not go home now that they're in South Africa. We also are doing more from something that's just getting ready to come down the pike in terms of training researchers at UCLA. So I'm telling you this with hopes that perhaps you might know of a postdoc or a recently hired academic, an assistant professor, who might want to come to be a part of our training program at UCLA. It's a translational training program, and the mnemonics are HAT, but it's a dissemination program. And we're really talking about cultural competence and congruence, and what are some of the elements that individuals need to pilot in order to understand if they can take something that's evidence-based and use it in another community, and how to do that in an appropriate way. So these fellows that we're hoping to enroll in our program will be coming in September, and they'll be staying for 2 years. They will live in their world for 9 months, come to UCLA for 1 month in the summer. They will be mentored by my team and people from all around the United States. So if you know of anyone who might be interested, please have them contact me by phone or by email, because we are looking for what we call very talented individuals who might not have had an opportunity to gain the kind of research skills that I think are very, very important in the 21st century. Finally, we have a center that's been funded in culture, trauma, and mental health, and there are about 6 research projects a part of this center. We're looking at the biological and the behavioral aspects of trauma in relation to cultural messages that also mimic the same kinds of behavioral reactions many times, and mental health practices and disparities. Some of these studies are extremely important. Dr. Michael Rodriguez, for example, is looking at interpersonal violence among Latinas, and he's been following the women for 4 years. They were pregnant with their first child at the time that he enrolled them in his study, and now the children are 4 years old. So he's looking at the parenting skills of these women who now have had children. Most of the women who have histories of interpersonal violence are still with their husbands who batter them. So this is a real reality when you look at interpersonal violence. Among some cultures, women are not going anywhere. Why? These women tend not to have any skills. They're undereducated, they're not employed. Where are they going? So we're working with him to be able to document the long-term effects of living in a violent relationship, so that he can develop an intervention that's appropriate with this population. These tend to be recently immigrated monolingual women. Very hard to find. These are some of the other people that we have on our team. About 3 or 4 of the investigators are Latino, and I'm very proud of that, because we are working in an interdisciplinary fashion with a variety of people from different ethnic and cultural backgrounds, and we're not having any conflict on that. And I think it's interesting that so many times you see people pitted against each other, Latinos pitted against African Americans because of job scarcity in Southern California. These are 2 groups that don't have a natural history against each other. There's no reason to have conflict. We're helping each other. We're not crabs in a barrel. And we really talk about the potential for conflict and how we can resolve it. But these are just the names of some of the individuals who are involved. We even have one guy who comes from UCSD to work with our team. That's Andres Ciola. So if you saw the video that was shown at the noon hour, this is the information on how you can purchase that video yourself. It's very powerful. It's a short history of some of the experiences of African Americans in this country and their contributions that are very positive as well, ending with President Obama. I want to thank you for allowing me to tell you about some of my very challenging work. I like to stay out of the box. I like to be controversial. I feel that that's the way to really push the science. It's good science. It's not easy to live this life, but it's the only life I think I was supposed to live. God told me that by the experiences that I had when I was a girl, that I wasn't always going to fit in, and that I would have to learn how to deal with adversity. So I'm dealing with adversity by promoting diversity. Thank you so much for listening to me.
If I may ask you to join the panel now, to the right here, and ask the panel to please come up, and if we could have the lights up full, please. Let me just mention once again that please jot down any questions that you have on cards. If you don't have a card, there'll be people on either side who can give you one. And if you have questions, comments, just raise it, and we'll collect them and integrate it into the conversation. Let me briefly introduce from your far left going to the right. For me, it's in the opposite direction. First, Reverend Deborah Hickman. She is the co-founder and the CEO of STAR, Sisters Together and Rising, is an individual who has done a tremendous amount of work around HIV in Baltimore, and particularly with black women and HIV. The second member of our panel is Dr. Charlene Brown. And Dr. Brown is the acting commissioner for medical operations at the Baltimore Health Department. She is a graduate of Harvard University School of Medicine, got her public health degree in Boston as well at Harvard, and worked internationally at USAID, and came about a year and a half ago, 2 years ago now, to Baltimore and to the Baltimore Health Department. And to her left is Dr. Maria Trent. Dr. Trent graduated from the University of North Carolina School of Medicine, went further north for her training at Boston Children's and Harvard Medical School in adolescent medicine, and has been here in the School of Medicine since when? 2002? 4? 1. And is an assistant professor. So thank you all for joining Dr. Wyatt on the panel. And let me first turn it to you, Reverend Hickman. How do you see some of these issues that Dr. Wyatt was raising connect with issues that we see here in Baltimore?
I think that the issues that Dr. Wyatt has raised are very relevant and very real issues that must be addressed, that they have been issues especially relevant to Baltimore that have been buried for far too long, that the community, the health community, the faith community, the business community combined we have turned our head the opposite direction and have allowed, especially in the area of HIV and other health disparities in the African American community, to get far out of control because we have not adequately addressed the issues. We have tried to bring in interventions that have been made in boxes that do not work for African Americans because African Americans have not been a part of the design of the interventions that have been designed for the greater part. That's not just related to the interventions, but it's also related to the treatments that are actually prescribed for the community at large. And so it is time that this conversation be had. When we talk about African American women, and in the last 18 years that Sisters Together and Reaching has been in community and doing its work, when we listen at the women and why they do not show up for their appointments at the community centers and in the hospitals, they're not showing up because the hours that the centers are open are not, not really hours that they can show up, and they actually do not speak to the issues that are going on in the women's lives, and no one actually is taking into consideration what the women are saying to them. Their voices are not being heard. The questions are not relevant to what actually is taking place in regards to their medical conditions, in regards to their social lives. And so there must be some interdigitation that takes place across all of those strata in order for us to do an effective job. And then you have the greatest marketers to go out into the community and say, this is the place and this is what needs to happen if we're going to stop HIV and other sexually transmitted diseases and also get a proper handle on other health disparities.
Could you comment for a moment on issues related to sexuality and discussions of sexuality and how that ties in, and some of the experiences that Dr. Wyatt was talking about and was reflecting on as it relates to women here in Baltimore and their risk for HIV?
Sexuality is a major problem, especially, for African American women. For far too long, we have been in silos. We have lived, I think, a great deal of our lives in a place of slavery, of believing that we have to have permission to be ourselves. We experience becoming awakened too late, at the age of 50, when we have severely abused ourselves and placed what has happened in our lives as women on somebody else. We have allowed ourselves to be in a place of domestic violence. First and foremost, we've always been taught that it's somebody else's fault before we actually see it as being first and foremost my fault, because I don't know myself. And there is no sisterhood where we can actually trust. Trust is a major factor, and that's where the institution of the church has a major foundation in our lives, and we have to come together as that faith entity and have a major discussion about what we are or are not doing, and maybe not doing so well.
Thank you. Let me, if I may, turn it to Dr. Brown and ask for you to reflect. You work on issues related to HIV, and from the perspective of the city, where do the issues that we've been talking about connect with your experiences, primarily in Baltimore, but also in Washington and internationally? And where could we be going with this? How should we be doing our public health work differently, our medical and health provider work differently?
Well, one of the things that was most striking to me about Dr. Wyatt's talk was this hidden, I don't want to call it an epidemic, but this hidden experience of child sexual abuse and how that can permeate so many different things. And so when we, as public health professionals, think about, for instance, increasing access to care for people with HIV or for people with any kind of medical condition, we talk about the barriers to care. We often talk about people struggling with substance abuse, or we talk about avoidance of primary care because of the cultural incompetence of the providers. We talk about things like Reverend Hickman noticed the inappropriate hours that don't coincide with the lives of working people. But one of the things that isn't sort of on the forefront of that dialogue is how does the history of child sexual abuse or intimate partner violence impact someone's willingness to engage in the healthcare system or to engage in an HIV prevention educational activity. So if we are doing HIV education, I was very struck by the points you were making about how would that how is that going to be received in the context of that person's individual history. And so I think that as we navigate that space between population-based health, which is public health, and individual-based health, we have to find ways to make sure that our interventions designed for large groups of people are structured in a way that they will meet the needs of individuals, which are going to be complex and different, sort of getting at the point that Reverend Hickman was saying about the sort of box approach. We can't allow public health to be a series of boxes that we apply to populations. We have to marry these lessons from individuals with the experiences we have addressing population-based needs.
Dr. Trent, you spend your life working with young people who both are highly vulnerable to issues of STIs, HIV, pregnancy, a whole slew of potentially significantly negative outcomes, and whose sexuality is also forming. And who are also vulnerable to abuse in multiple different ways. How do we take this and do some of our work with young people differently?
So there were a lot of things that came out for me. I put all these notes while she was talking. But I think in my area of research is in sexually transmitted infections, sometimes how it relates to HIV, but sometimes not, because we see a lot of some other sexually transmitted infections that are really impacting on the bodies of very young women. And my work is basically on how to get them to take better care of themselves when they're doing it on their own. And I think the first thing that she talked about for me was this sense of community, and how we can create a sense of community with and to each other, that we can prevent HIV and keep it from spreading. When so often people are disenfranchised, stigmatized, or often really very young people who are both of those things, and sometimes even more vulnerable, often abandoned. And I think that more recently I've begun to think about this concept of human rights for adolescents. And one of those key rights for them is really that they have a parent that's involved and walks with them, even through late adolescence, and holds their hand through that process, or at least has a hand available. And how that can transform a sense of safety, which is one of the things that emerged from this talk for me, and how girls can develop a sense of sexual safety. And then how difficult it is for our adolescents in places like Baltimore to sort of have sexual freedoms that adolescents in other communities can have, because they can't assess their risk. The STD rates are just too high. You can't tell whether or not you're going to get chlamydia from this person because the rates are too high, when we look at our epidemiological studies that show us that it's common. And so how do they assess risk, and how can we teach them that when the community is not free from disease? How do they become into their sexual selves when having an STD becomes really very commonplace? So that's one of the things we have to deal with. And then finally, I think we have to be prepared to take care of adolescents from urban communities who are often minority, who are often poor. And one of the other hats that I wear over in the School of Medicine is that I've worked really very hard over the last 5 to 6 years to develop cultural competency training for individuals who take care of mostly teenagers in Baltimore. We've done work with the health department. We've also done work over in pediatrics to try to change that. Because I think that oftentimes we have a big issue with workforce diversity. So we're not having, so you talk about it in terms of having researchers who understand the issues, who understand the culture, but that also plays out in clinical practice as well. How do you talk to an adolescent girl and her mother when you don't understand their history, or you're really rushed and you only have 15 minutes? How can you do that? And then in a setting like Hopkins, how can you learn that in a very short period of time? And so I think we really have to invest in really valuable training, not sort of this one-day thing or a module kind of thing that a person does alone on the internet, but allows them to grow and engage with patients in the clinical setting and also as researchers. And I think finally, I'm big, you have to train researchers. And I think that when we don't have a lot of people like Dr. Wyatt who are very seasoned, who can sort of take your hand, I have to say that it has to be sometimes people who are not of color, who have to be willing to embrace young trainees from disadvantaged backgrounds or different cultural backgrounds or ethnic minorities to help shape researchers who can come into the field and really add to it.
Let me ask all of you, and Dr. Wyatt, perhaps you might lead off. How do you engage parents in some of these conversations, particularly given the taboo that you talked about?
Well, you know, I've not met a parent who didn't want to be involved with their own children in some way, maybe very marginally. Most parents want to be involved. They simply don't know how to assume a role of a sexual expert. I found that when you're talking about reproduction and some of these difficult topics that have to do with sex, most parents don't know either. So we're asking them to be involved in something that they really should be listening to. And I think when I developed a sex education program for the elementary school where my children went, I developed one for parents as well, and I actually used the same curriculum because they didn't know how they got the children that we were teaching, and you know, it was amazing. So what I'm saying is that I think that if we put too much pressure on parents to be experts, first of all, I think we push them back to feeling threatened. Secondly, we have to find a way to make it easy for parents to come in and make this a family-based program. Food is always a draw, having dinner together, so that they get taken care of the family activities without having to do something extra. Having evening and Saturday programs works for parents who work. And I've missed almost every PTA member meeting my children ever had when they were in school because they were always during the week when I could never get off of work. So we need to do better about making it possible for parents who really can't get away to do those kinds of things. And I also think that in some kind of incentives also help people. We have to admit, if you give people movie passes, they probably will come in to participate. And what's wrong with giving the family a movie pass? You know, we work for money when we can get it, and a tiny bit will do better than none. So why can't we look at and appreciate the fact that incentives do motivate people? And we're using incentives in drug risk reduction now, and find that people stop using drugs when you pay them to stop using drugs, and then they go on and live their lives, and you don't have to pay them anymore. So I guess what I'm saying is we have to make it exciting. We have lots of games in our interventions, family-oriented activities, and an acknowledgement that we have to work around their schedules and not around ours, making it easy for them to connect with their children and allowing them to learn before we ask for them to be the expert. In fact, they don't even have to talk about sex if they don't want to. Some people have such traumatic histories they probably shouldn't teach their children because they're going to teach them how horrible their experience was. But at least if they can be in the same room with someone else who can do it, then I think we can get them involved.
Would anyone else like to comment on that? We have a number of other questions, so let me go on. I need to now, in truth, in listening, let you know that there are some in the audience who have done much of the landmark male circumcision work in Uganda. And the data from Uganda, and there are real questions of whether you can take and extrapolate the virus and the findings from sub-Saharan Africa to the United States. But that having been said, the findings from Uganda as well as from Kenya are pretty impressive in terms of the effect of circumcision. and not only in terms of reduction of HIV, but reduction of herpes simplex virus and reduction of HPV as well in men. And that some of the recent findings show, in fact, that washing increases the risk, does not diminish the risk. So aware that you can't extrapolate directly to the United States, what is your sense or feelings? And again, I raise this for the entire panel, not just Dr. Wyatt, in terms of recommendations that you might give in terms of advocating for or not male circumcision.
Well, first of all, let's look at this whole issue. Circumcision is usually done in many tribes and nations in other countries when boys are going through puberty, not as an adult, or they're very young. It hurts, I understand, no matter when it's done, but they're not adults. So this is something that the Western world has created as the solution to this problem. Secondly, everybody knows, or should know, that the first study that was done regarding male circumcision was done with, I think, the French, okay? And that there were some real ethical problems with that study, because I understand the people who were positive were allowed to go on infecting people, and they weren't told that they had seroconverted to being positive during the study. And yet that study was published in a top-tier journal. Now, if anyone else had done that, they would have had it under the prison, okay? But that study went on to then motivate other people to do the study. So again, here we go with Tuskegee. You just can't step over these ethical issues and for everyone to be on board with that. Thirdly, people have done this practice on their own, and then when Africa was colonized, they were told to stop doing it. So now people tell them to do it. Well, wait a minute. You just can't ignore the mixed messages that have gone across historically. So who knows what's best for whose penis? Fourthly, when you see a white hand holding a male adult, well, you wanted to talk about it, here it is, holding an adult male penis, that doesn't look right. Because there's this obsession about the black male penis. Did you all know that? And if you don't know the history of it, then you wonder, well, why exactly is this being done? Did anyone really try to wash? Because I'm not convinced at all. You know, there are people who will tell you, no, you're not going to be able to minimize the disease by male circumcision. It doesn't have any value for men. And the last one is, nobody's studying these men to see what kind of sexual dysfunction they're going to have for the rest of their lives because of inappropriate scarring, because it's always not done, also always not done by someone who knows how to circumcise a penis. Who circumcises penises? Obstetrician gynecologists do. Well, they're not doing this procedure. So I have lots of questions about it. Not just because I think that it's been done in a way that wasn't discussed, but because it's being done by people that I'm not clear know what they're doing. And if you alter a person's sexual pleasure for the rest of their lives, they're going to be having sex anyway, trying to work it through. And what's happening is these guys sometimes aren't healed, and they have sex with women, because it has no effect on gay men. And the women then are more likely to become infected because the men are still sore and they're chafed and red, and then they hurt the women. So it's got lots of problems, and when you see the efficacy of it, they don't talk about all these other issues, and I don't think we ought to do anything to people's genitals to a group of people who've been so grossly manipulated, unless we know what we're doing ethically, medically, psychologically, so that these folks can be well, not just from HIV. That's not the only thing that can kill you. I'm passionate about that.
I sensed that. I picked that up, and I'm not even a psychologist. Let me put Drs. Brown and Trent on the spot. Comment.
Aren't there some expert researchers that did the landmark studies on male circumcision in the audience?
I think it's interesting. I think the discussion we're having is interesting because I don't think we often have these types of discussions. There is some data that suggests that circumcision is old, it's time, it's ancient, and that it's been very effective for certain cultures in preventing disease. And I think the situation in overseas in certain parts of the world are very dire right now, and I think that we need to evaluate all the tools that can be potentially life-saving for people to prevent the continued spread of HIV. That said, I think that there's some data, and the new data is compelling, and there's some new data about how this may roll out in the United States. But I think that as with what we've seen in Europe, there are parts of the population who culturally find this approach to be problematic and have written about it vociferously in both the lay and scientific world. And the question is, how will that play out for a large population of people? HIV is a problem, but when you have, in Baltimore we look at around 2% of people, how does that play out from a culture perspective and a cost-effectiveness perspective to circumcise everyone? And I haven't seen that data yet. There's some data that shows that a good portion, 80% of newborns were being circumcised some time ago in the United States, including African Americans, and that didn't prevent the development of HIV. And so I think that I just take Dr. Wyatt's passion in that we need to be cautious before the American Academy of Pediatrics, which is sort of my sort of body and other people, subscribe to that as the end of HIV, because I think there are a lot of other issues that we have to address. So I think we need to do the work in the United States, and I think we need to try to figure out some strategies that the community is going to embrace and involve individuals who are going to be affected by it in that research.
Let me raise one last question, and I would ask maybe we'd start with Reverend Hickman and then work our way down. And it's a overarching, I think, question. How do we build the idea of sexual health? Not just the notion of risk prevention, but sexual health, mental health, physical, spiritual. The integration of self, is, as you were talking about, Dr. Wyatt, into a primary care safety net, into our sex education, into our health promotion, into how we go about doing our work.
I think that first and foremost, I would invite everybody to purchase a copy of Stolen Woman. It's a very interesting read. And I think that after you've read Stolen Woman, that you get the next book, and you learn something about sex. You become a sexologist.
I believe she does not get a cut on these books.
I don't get a cut. But I think that we have to actually, first and foremost, learn about sex and become comfortable with actually making sex sex a daily part of our normal conversation, not, destigmatizing talking about sex. It's not something dirty. It's not something that we just do behind closed doors, that it's okay to talk about sex. When we talk about having that conversation with our children, that we don't wait until our children are 13 and 14 years old to have the conversation, that we start having that conversation before they get to that tender age of 7 in our households, that we make it a normal part of conversation, that we make it a normal part of our worship services in our churches, and that we start talking about disease and sexual transmitted diseases, and we normalize the situation that it's not something that is this it's not it's life. Life is happening, so that we can get to the place where we start saying, I am aware and I am going to take better care of every part of me.
Thank you. Dr. Brown?
I think it's very important for us as we think about sexual health to do the things that Reverend Hickman said in terms of creating a space where people can talk openly about sex, about their questions, about their concerns, about their bodies. And when we talk about risk reduction in public health, we talk about community risk reduction, individual risk reduction. Sexual health is part of the path to risk reduction across the board. I mean, that's how we get there. It's the foundation of risk reduction or safer sexual behaviors. All of the things that work on HIV prevention and sexually transmitted disease prevention are focused on, and reducing the spread, interrupting the spread. Sexual health is a part of that. The dialogue about it, the engagement and care and the feeling of safety when dialoguing with your provider about it, the peer communication about it, all of that is a part of sexual health and is a part of our responsibility as public health professionals.
Maria?
I think we have to also start very basic for young people. And, you all are talking 12 and 14, but my 4-year-old can tell you where her vagina is. And so I'm very proud of it. Maybe it's too soon. I was where she goes, she can't tell everybody. But you got to know the names of stuff. Right. But I think what I see is when I see a relatively late adolescent, and one of my questions for girls is, how many openings do you have in your private area? And I've talked to young women in this city who've had a baby who think it all comes out of one space. I mean, to me, that's a conversation I'm having with 12-year-olds in front of their mothers, and then I put the mother on the spot and say, you've got to go out now, and if your daughter has any questions, if you have any questions, I want you to talk to your mom about it. I think oftentimes people think that adolescent doctors, we take their kids away from the parent and have these secret discussions. But I want them to talk to their moms about it, but I also need the parent to know that this is a safe place to come and talk to me about it, and these are the kind of things you need to talk to your daughter about it. If she's having her period, it's way past time for you to be talking about these kinds of things. And we have young girls in the city who are menstruating, very early. 12 and a half is the norm, but we have 10-year-old girls who are having their periods. And so they really need to learn about sexual safety very early. Just recently in our clinic, we diagnosed a 6-year-old with gonorrhea. I mean, it was traumatizing for our entire group. But to sort of say, have we done all the right things for this child? But those are some of the realities I think that we're dealing with. And working with the abuse team, is it abuse, is it not, did something happen? I think really working through those issues. So I think we can never start too early to begin to teach sexual safety. And I think we have to have strategies that work for the developmental level of the child. I think we also have to empower our parents not to let go. Many of our parents started parenting very young in the city, and they've worked hard to create stable lives for their children, sometimes working multiple jobs. But I think to encourage them to stick it out, at least age 18, when you have your late adolescent who is functional, at least have your hand available for that adolescent. It's a big issue for me right now because they really need it. And I think we didn't talk about it so much today, but the implications that HIV has on young people who've lost a parent to HIV. We have even really kids whose grandmothers have swooped in and have really taken over, especially kids who are not infected themselves. And they're really struggling. They miss their mothers. They're worried that their grandparent may not be here any longer. And those are some of the realities that our kids are facing every day. And I think that, I think we have to think about those issues. And I think finally, women with HIV, we're learning, want to also have children. They have other needs, and we have to begin to talk about them in this context of clinical care, not just the young adolescents, but even sort of the 25 and 30-year-old woman who's sort of out of my grasp clinically about what their fertility desires are, how they can prevent transmission to an infant, to their partner, and really dealing with the issues on the ground.
Dr. Wyatt, you have the last word.
On sexual health, I would agree with the panel. It can't start too soon. I think the absence of dialogue is education. It says, it's not important for me to tell you, you find out everywhere else. Our society is allowing children to be educated by media, by each other, by misinformation. And I think that if we, as a responsible nation, want to diminish the high rates of unfortunate sexual experiences, people need to be educated. You can see the benefits of sexual health in countries where the government actually makes that a mandate for everyone. And it's really not a difficult thing to do. It doesn't have to have a religious base to it. It's simply factual. It's just understanding, having the information. I think we all deserve it, and we ought to do something about it now. I think we can do it. I have books in my office and anatomical charts. And whenever someone says anything that I think is a teaching moment, I pop out those books and that chart, and there I go. It's just that easy, and they take the charts home with those little mirrors. Each of you should have a little mirror today. If I had my heart in it, I would have brought you some from Los Angeles.
Thank you. Thank you all. And we have many more questions, but Dr. Wyatt has a flight to catch. Yeah. So thank you very much for a stimulating presentation.
You made it there.